So today Dr. Sunil is traveling, so I got a chance to be with you all for today's session. Thank you, Jean, for agreeing to be a part of this program. So you have So Dr. Jean is a palliative care physician from India, and he moved to Canada in 2018. He did his clinical fellowship from Toronto and a clinical research fellowship from Princess Margaret Cancer Center. He has special interest in global oncology, palliative care, advanced pain management, and telehealth palliative care. He has several publications in palliative care and oncology journals, and he works very closely with many projects at Pallium in the last few years. It's good to introduce Jean in this session. Thank you so much for being a part of this program. Over to you.
Thanks, Sridevi and Supriya, and welcome everyone. Are you able to hear me okay?
Yes, you are very clear.
Yeah. Okay, great. I'm just gonna share my screen. Are you able to see my screen?
Yes, not in the yeah slideshow. Yeah.
That's weird. Is
No,
it
it's still
showing for
black.
you?
Yeah, yeah, no.
Yeah,
No,
it's not
it's
showing
not.
for me either. Maybe it's just
Not sure.
taking a second. Let me try again. But you can also get to meet the audience. Maybe I'll start, and then I'll just go down the list and call people to just say a bit about themselves, where they work, and kind of their interest in palliative care. So as Dr. Sridevi said, I'm a palliative care physician here at Queen's University in Kingston, in Canada. Before coming to Canada to do my fellowship training, I was working at MNJ Institute of Regional MNJ Institute and Regional Cancer Center in Hyderabad. I'm originally from Kerala. So that's a bit about me, and I'll get a bit more into the details of global palliative care, India versus Canada, and stuff like that while we're doing the lecture. But in the meantime, maybe I'll just call on Dr. Ashok Mathews first on my list here. Just a brief introduction.
Yeah, yes, I am Ashok Mathews, and I'm basically from Kerala, but I have settled down in Chennai, and I am working with a trust called Destiny Pain and Palliative Care in Chennai, and I have been working in that trust for the last 14 years as a palliative care physician. I'm basically qualified as a ENT surgeon, but turned out to be a palliative care because I found it much more satisfying in my dealing with the patient and how we could help them in their sufferings. So that is why that is the reason why I chose palliative care and moved out from my basic this one as a ENT surgeon. But I enjoy this work, and I'm very compassionate on this field, and I would like to learn more. That is why I have come and joined this global fellowship. I think that much introduction is okay with you now, but later on we'll know more about each other.
That's great. Thanks, Dr. Mathew. Next on my list is Dr. Meera Sunil.
Good evening, sir. Myself, Dr. Meera Sunil. I am from Kerala, settled in Trivandrum. I have completed my MD anesthesiology from Tamil Nadu in 2021, and after that I was working in a private hospital in critical care and anesthesia department. While that time, I have joined in global fellowship program. Because during my PG period, I am interested in pain clinic and this palliative care and all. That's why I joined this program.
Great.
Thank you, sir.
Welcome, Dr. Sunil. Next, I have Dr. Biju Gopi.
Good evening, sir. My name is Dr. Biju. I am working in Medical Trust Hospital, Ernakulam, Kerala. I'm a specialist palliative physician here. I have just joined. I was before working in Lakeshore Hospital in Ernakulam itself. There also as a consultant palliative physician. In both these hospitals, we have started palliative care after I came. And we started the home care also, and which is going on very well in the present hospital. We are taking care of end-of-life care, both at home as well as the hospital, and pain management for mostly cancer patients with advanced cancer diseases. And also end organ failure patients from other departments who have been referred to us, including CBA patients for chronic management. It is going on well with in conjunction with other doctors. We are trying to spread the word around so that more and more people are aware of this kind of facilities in the hospital. This is more of a tertiary hospital, so it's quite rare to have a very extensive palliative care facility with home care facility in a tertiary level private hospital. But we are promoting that, and it's been a success. Thank you, sir.
Thanks, Dr. Gopi. Next, Jagrati.
I am BDS from Mumbai, and I had come across, my journey is very interesting. I had come across in USA when I was there for 5 years, the palliative care term. And I had thought that, that was in 2003. And that time, I thought that's my calling. But I took formal education of palliative care in 2018 from Pallium. And now I'm working in a private hospital as a physician in Mumbai as a palliative care physician. And mostly so far, so my experience of working it since last 3 years, and mostly I have got so far, the patients are all cancer and neurology. But I had done my foundation and refreshers and advocacy, everything from Pallium. But to enhance my knowledge, I joined this course. Yeah, thank you.
Welcome, Jagrati. Next we have Parul Raina.
Hello, good evening, sir. I have done MD in anesthesia from GMC Jammu, followed by senior residency from AIIMS Delhi. Now I'm currently working as an assistant professor in UP Greater Noida. I had my own share of personal experiences, which drew me closer to the chronic pain, especially, and palliative care. That is why I thought I will learn more and join this course, sir. Thank you.
Thanks, Parul. And next, Dr. Punita.
I'm Dr. Punita. I'm from Coimbatore. I'm also a practicing anesthesiologist for past 30 years.
Punita, we can't hear you.
Hello, can you hear me now?
Yeah, that's better.
Okay. So I'm Dr. Punita from Coimbatore. I'm working in a medical college here, private medical college. I'm a practicing anesthetist for past 13 years. I was also introduced to palliative care from the year 2018 only. Like it was just incidentally I found out pallium, and then I started getting interest. Initially, I was interested only in chronic pain, but then I understood there is a lot of scope in palliative care. There is need in palliative care, and that's why it drew me close. And I like the way of education which is given by Pallium India, which is continuous education. And I felt there is a lot of support. They handhold in many moments. You don't feel alone when you make decisions. So it was total. Like they helped me in starting a practice in palliative care also. So I'm continuing now. For the past 4 years, I'm doing it.
Thanks, Dr. Punita. And next, Nadeem.
Nadeem, can you unmute yourself?
Hello.
Hi. Hello.
Yeah, we can.
Hello. Right.
I'm
So I am Nadeem Kosliwala. I am based in Trinidad, which is an island in the Caribbean in the West Indies. I initially was in internal medicine, but it's while working there I had started an interest in palliative medicine, but there are very limited palliative services available in our country. So I started working with one of the very few companies that do offer palliative services. And we're really hoping to try to expand and provide more of that for our patients in the country because it's very limited. So that's why I joined this course over here.
Thanks, Nadeem. Welcome. And next, I have Ravi Kiran. Did you
Can you
unmute?
unmute and speak?
good evening, everybody. I'm a radiation oncologist. I've done a part along with oncology. I have been doing palliative care and the chemotherapy. So one way or the other, I was being a part of the palliative care since past 5 years. But since 1.5 years, I've completely being into the palliative care exclusively, and I have found something which is more useful and helpful to the patients, as most of our oncology patients that have come this stage 4 recurrence and relapse. And based on that, I even dropped my super specialty for the interest in palliative care, and I'm completely involved in here. And I'm going to join in Tirupati unit to establish the palliative medicine department. Thank you.
Thanks, Ravi Kiran. Got Bindu next.
Hello, everyone. I'm Dr. Bindu. I did my medicine from India, and I did in masters in internal medicine in UK. Then since then, I've been working in the stroke department for the last 7 years. While working in the stroke department, we see a lot of patients, who need long-term rehab. So there is no cutoff. I think we struggle a bit to say to the family or patients when the treatment should end. I think that's why I want to explore with the palliative medicine to see more and learn more about it. Thank you.
Thanks, Dr. Bindu. We have Khushbu next.
Good evening, sir. Myself, Dr. Khushbu. I'm a consultant anesthetist working in a private hospital right now. I have a special interest in cancer pain management, and I want to explore the palliative medicine and want to make the people, the healthcare professionals, aware about the palliative medicine, because many doctors are also not aware of palliative medicine as a branch as such. So layman, so it's like so I have that's why I have joined this course.
Thanks, Khushbu. And Kavin Kumar.
Hello, sir. Good evening. So I am Dr. Kavin Kumar, a public health specialist with MD in community medicine. So it was some of the personal experience are there, and it was one interview by Rajagopal sir on his book with the Vakyat Veri. That's opened up my insights about palliative care. And right now I'm exploring about primary palliative care and how to establish how to replicate a good models like in the focus of primary palliative care, like building up an NGO, or I am working up with the little bone models to work on. So thank you very much.
Great, thanks, Kavin Kumar. Dr. Vidya Saharan. Just unmute, please.
Hi, sir. Good evening. I finished my MBBS in last year, and I started working in a cancer center in Chennai. So there comes my interest in palliative care. So it deals more with the emotions and everything whatever the patient feels about and everything under it in a palliative care. So our unit mainly as a trust hospital, they are doing the palliative care for the past 17 years. So I got interested with them and started doing a fellowship.
Great, thanks, Dr. Vidyasaran. Next, Shaji.
Good evening, sir. I am Dr. Shaji from Kerala. I am anesthetist and I have physiatrist also, physical medicine rehab specialist. And I'm working in government sector, insurance medical service. So in our sector, we started on mobile palliative unit. So I was involved with the palliative care work with the home visit. I am basically interested in chronic pain management, disability management, especially disability, children with disabilities, cerebral palsy. So I found this palliative India, the coaching is very good and very interested. That's why you are here. Thank you.
Great, thanks, Shaji. Welcome. Dr. Yadav.
Hello, I'm Dr. Yadav. I was working at Trivandrum Medical College. Now, at present, I am working at Kollam Medical College. I have some long association with Rajagopal sir, and in a way, know many people in Pallium. And I think we work together in SHS, Dr. Jean. And I know somehow I got interested in real palliative work. That is why I am the person.
Thanks, Dr. Yadav. Nice to see you again. Dr. Ambu. Maybe Dr. Ambu might not be available to introduce themselves. Those who are not available to introduce, feel free to just put it in the chat. I know we've had a couple of introductions in the chat. Next, I have Dr. G. Nair. Okay, they may not be available either. Priya Ramakrishnan. Okay. Styru Philip already has put an introduction in the chat because they're on a train. And Dr. Oladayu is in clinic, so he's put an introduction in the chat. And I think the last on my list is Sirish. Is Sirish available?
Hello, sir. Hello.
Yes, go ahead, Sirish.
Good evening, everyone, sir. I'm Dr. Sirish. I'm a pathologist by profession, and I'm working as an assistant professor in Visakhapatnam in Gayatri Vidya Parishad. And I was very much inspired by Sri N.S. Raju, who has introduced me to this palliative medicine. For me, palliative medicine is a gateway to explore my capabilities, to see something different I can do for the patients, which involves both physical as well as social and spiritual aspects. And I'm very grateful to Pallium India to give me this opportunity. And I indeed am very much obliged, and I will try to develop my skills and do my best at my capacities. Thank you, sir.
Thanks, Suresh. So I think we can get started now. It was great to hear the introduction from everyone. It gave me a sense of, the broad kind of range of interests, different kind of professions that people are entering into palliative care from. We also have people from outside India over here. We have, all the way from, we have a couple of surgeons, we have some oncology people, we've got community health and dentistry, and I know one of the people mentioned that they've just finished their MBBS and they're joining. So and then some people are looking at adults, some people are looking at pediatrics. So it's great to see kind of the broad interests and kind of background of all the participants. I'll tell you a bit more about my own kind of background as we go through the slide deck, but the focus of today's lecture is going to be on global palliative care. I'll talk a bit about what are the challenges in integrating of palliative care in global health. I'll kind of focus on oncology as a case example, because as I'm sure many of you are aware, most of the literature around palliative care is based in oncology palliative care. Most of the RCT level evidence of palliative care comes from oncology. Non-oncology palliative care is more kind of getting established, and oncology palliative care is a lot more evidence. So I'm going to use that as an example, but everything I say kind of applies to equally to non-oncology palliative care as well. Supriya, can we go to the next slide? So I don't have any kind of financial disclosures related to this talk. Next. So these are the objectives. We'll be talking about how to integrate palliative care in global settings. I'll give some specific examples from my experience working in both India and Canada, and then also discuss some specific examples of possible solutions to the lack of access in palliative care globally. When I came here from India, like I thought that in Canada palliative care must be 100% available to everyone who needs it, as it was a high income country, and I thought high income countries had kind of figured out the issue of access. But working here now for 4 or 5 years, I've realized that even in Canada there are pockets and areas where there's problems in access to palliative care. So we'll talk a bit about how access to palliative care is a challenge in low middle income settings like India, as well as high income settings like Canada. Next slide, please. We can go to the next slide. So this is the definition of palliative care, which I'm sure all of you have heard many times by now, so I'll not go into it. This is from the WHO, but this just kind of grounds what we're going to be talking about when we say palliative care. Next slide. This is a figure many of you have probably seen again. On top is kind of the old concept of palliative care being something that is delivered just at the end of life, towards the newer concept, which is palliative care has a role from the time of diagnosis and kind of up to bereavement level care. Next slide. And this is the bow tie model of palliative care, which is one of the more modern kind of models where you can see that palliative care has a role even in curative intent treatments, and it has a role in parallel with curative care, in parallel with survivorship care. So a lot of the literature now is focused on the role of palliative care in survivorship. We, I'm sure you do the same, but we also manage pain and other symptoms in patients who are actually on a curative pathway. So it is not restricted to those who only have incurable diseases. So this kind of reflects, this bow tie model kind of reflects our current thinking about palliative care. Go to the next slide. So as I said, I'm going to use oncology as a case study, but everything I talk about applies to non-oncology palliative care as well. So there have been a number of trials in the last decade, starting with the Temel trial in 2010. In Canada, we had the Zimmerman trial in 2014, which was at the center where I did my training at Princess Margaret in Toronto. And so there have been, systematic review level evidence now that palliative care can improve symptoms, quality of life, satisfaction with care, not only for patients, but also for their family caregivers. Next slide. As a result, several national and international bodies like the American Society for Clinical Oncology, the European Society for Medical Oncology, and of course WHO itself recommends early palliative care within oncology care. And as we are building the evidence for non-oncology palliative care, I think we're going to see recommendations in a non-oncology palliative care as well. Next slide. So how does early palliative care help? Of course, we are experts in symptom management. We help patients to cope with their disease trajectory, help in treatment decision-making, and also help in advanced care planning. And like I said, it improves outcome measures not only for patients, but also for family caregivers. Next slide. How should we integrate palliative care in oncology care as a case example? So the group from MD Anderson in Texas, they did a Delphi survey of international experts to achieve consensus on integration of palliative care. And some of the criteria that they came up with, so presence of an interdisciplinary team, presence of outpatient palliative care, so like a palliative care clinic, routine symptom screening in outpatient oncology clinics. So for example, here in Ontario, the province that I'm currently in, all of the cancer centers have to routinely do Edmonton Symptom Assessment System screening for all patients that walk into the cancer center for any of their visits, whether they're visiting the medical oncologist or radiation oncologist or surgical oncologist or palliative care team. They have to do an ESAS with each visit. So systematic screening is one of the things that's recommended. And then early referral to palliative care. Next slide. Even though we have all this evidence and recommendations, there are still questions that remain. So some of the questions we're still trying to figure out: who should deliver palliative care? And there are now studies looking at palliative care delivered by specialist teams, so specialist palliative care physicians and nurses. And there are studies looking at nurse-led palliative care versus physician-led palliative care. And there are studies looking at primary palliative care versus specialist palliative care. So primary palliative care, which one of our audience members had referenced earlier, primary palliative care is palliative care delivered by a non-specialist team. It can be an oncologist, it can be another disease specialist such as a neurologist or a pulmonologist. It can be a general practice or family medicine physician. So who should deliver it? The second question is, when should it be delivered? The earliest trials of palliative care were looking at delivering palliative care from the time of diagnosis. So when they're diagnosed with an advanced illness, having automatic palliative care referral. Now there are trials looking at what is called targeted early palliative care. So the idea is not all patients at the time of diagnosis of an advanced illness may need a specialist palliative care visit. So they're trying to target early palliative care for the patients who have a high symptom burden. So that's another important area of trials that's coming up now. And finally, where should it be delivered? So there are different models. We talked about clinic-based palliative care. There can be home visiting palliative care. There's inpatient palliative care. So where's the best way to deliver palliative care? And of course, all of this will vary depending on individual context, what's available, and that sort of thing. Next slide. So with that kind of introduction, we'll get into the global burden of serious health-related suffering. I'm going to share a few articles related to the global burden of serious health-related suffering, or SHS. One is by Sleeman and colleagues. This was published in 2019. And what they were trying to do was to project the estimated burden of SHS in the year 2060. So they used data from 2016 to try and estimate in 2060. And they found that, in the year 2060, an estimated 47% of all deaths globally will have serious health-related suffering. And that's going to represent an 87% increase compared to 2016. Of course, the majority of this will take place in low-income and middle-income countries. And the highest proportion of increase of SHS will be in low-income countries. And most of this will be driven by cancer-related deaths. Next slide. So specifically about cancer, 16 million people will be dying with cancer each year and having SHS related to that in 2060. And again, the great burden of this will fall on low-income countries, with a 400% increase between 2016 to 2060 compared to high-income countries. Next slide. So this is a kind of an atlas giving a picture of what that's going to look like in 2060. The dark green represents a significantly high percent in increase in serious health-related suffering, and the light green is a relatively lower percent increase in SHS. So you see that most of the high-income countries, so if you look at North America, Canada over here, the US, if you look at Australia, Western Europe. So the burden of disease is actually not going to fall on these high income countries, but it'll be more on the low and the middle income countries. And just keep a note of this map, because later in the slide deck we're going to see another map which shows the availability of palliative care service to meet the estimated need, and we'll compare both these maps. Next slide. So if we look at what are the health conditions that are driving this global burden, we know that cancer is going to be the main driver, but you can see in the top 5, cerebrovascular disease was one of them. So one of our audience members was talking about stroke rehab and palliative care. So that's one of the second most common after cancers. And then lung disease, dementia, liver disease, those are all in the top 5. Next slide. If we divide it by income, in low-income countries, injuries is third on the list, but otherwise in low and middle-income countries, it's pretty similar to in high-income countries, in that cancer, cerebrovascular disease, lung, liver, dementia, these are going to be kind of the main drivers of the global burden of SHS, regardless of whether it's a high income or low middle income country. Next slide. This is just looking at cancer deaths specifically. In high income countries, lung cancer is going to be the main driver, whereas in low and middle income countries, breast cancer is going to be first, and then lung cancer is going to be second. Next slide. So the recommendations from the Sleeman study, so they say that the global burden of SHS is going to almost double by 2060, and that's going to be a higher proportion in low middle income countries. Without improvements in palliative care integration into health systems, especially in low middle income countries, we'll have a failure to relieve the suffering of millions of people. Next slide. So we looked at what is the estimated need for palliative care. Now we're going to look at what is the actual availability of palliative care to meet that need. So this is from Kark and colleagues. They've been doing a mapping level of palliative care development type study. since 2006, that was the first time they did it. And then every few years, they keep updating the map based on progress in palliative care globally. And the most recent map is from 2017, which they published in 2019. So they do an online survey of 198 countries on 10 indicators of palliative care provision. So they look at things like morphine availability, education in palliative care, national level policies, integrated palliative care into public health and things like that. And based on those indicators, they categorize countries into 6 levels of development. And those 6 levels extend from 1, which is no palliative care activity, all the way to 4B, which is advanced integration of palliative care. So if you see here, category 1, no known palliative care activity, that's about a quarter of the countries of the world. And if you look category 1, category 2, which is where there's capacity building initiatives are going on, but no actual palliative care clinical delivery, and 3A, which is isolated provision. That means there are certain pockets of the country where there is some palliative care provision. More than half of the countries globally will fit into one of those 3 categories, either 1, 2, or 3A. And India is at 3A, which is isolated provision in some pockets. Next slide. So this shows what those different categories look like. The dark blue is 4B, that's advanced integration. And as you can see, North America, Western Europe, Australia, these countries have, or these regions have advanced integration of palliative care. And then the light blue, or the light brown, those are no known activity or kind of very low or isolated provision of palliative care. So India is, like I said, it's a 3A, which is isolated provision of palliative care. Canada is 4B, which is advanced integration. And so if you compare this map with the previous map, we can come to the conclusion that the countries that need palliative care the most, that means they have the highest burden of serious health-related suffering, they're also the countries that have the least palliative care provision, and vice versa. Next slide. So highest level of provision of palliative care is only available for 15% of the global population, and it's mostly concentrated in high-income countries. And so with an increasing need, palliative care is not reaching the levels required by at least half of the global population. Next slide. So in global palliative care circles, this is called the access abyss, which basically means that the countries that need it the most are actually having it the least. This term was popularized in a Lancet Commission report in 2018 by Knoll and colleagues, where they talked about alleviating the access abyss in palliative care. So one of the ways to measure the access abyss is opioid availability. So we look at morphine consumption. So there's a statistic that out of the 298 metric tons of morphine distributed in the world, only 0.1 metric ton goes to low-income countries. If we look at Canada, we have 68,000 milligram per patient in need of palliative care, which is much more than needed to meet all the palliative care needs. And of course, in this context, we talk about the double epidemic, whereas in countries like India, where we have a epidemic of shortage of opioids, in countries like Canada, we have a epidemic related to opioid deaths because of overconsumption of opioids. Next slide. So this is what that map looks like. So you can see here in Canada, we have 3,000% of the global need of morphine has been met, whereas in India, only 4% the estimated need for morphine is being met. Next slide. So now I'll talk a bit about kind of my own journey in palliative care, and I'll use these two pictures. The picture on the bottom right is the outpatient cancer department in the MNJ Institute and Regional Cancer Center in Hyderabad. So this is where I was working after basically I did my MD in anesthesia, and like many people during the introduction, they talked about meeting Dr. Rajagopal and then, deciding that they needed to make a career change. I had the same kind of experience where, I spent some time with Pallium India while I was working an anesthesia in Kerala. And after that, I moved to Hyderabad to do the 1-month course in palliative care. And then I started working in Hyderabad. This setting, it may be similar to many of the settings that that you all have been working in. When I work at the clinic, the outpatient clinic at the palliative care department here in Hyderabad, we were seeing maybe about 50 or 60 patients a day. They came from several hundred kilometers away to come to this center, which at the time was probably the only center in the state that had morphine availability. They were usually below poverty line. They were kind of rural agricultural workers who came there. In terms of our staff availability, we had, I think, 2 doctors at the time in the clinic managing that volume. We had nurses in the separate clinic, but they weren't part of the assessment because they were managing wounds. They were doing morphine trials for patients who were in severe pain. So it was a very chaotic type of setting, which, for many of you, this might be a familiar kind of story. In terms of opioid availability, the only opioids that we had to work with, we had morphine, oral and injectable. We had fentanyl patches, and we had methadone, which came on kind of towards the end when I was, maybe a few months before I left to Canada, we started having methadone availability as well. On the left screen here, this is where I came to do my fellowship. This is the Princess Margaret Cancer Center in Toronto, and the palliative care clinic is located on the 5th floor of that building. In this clinic, the daily kind of patient load was about 8 to 10 patients. So we'll see 8 to 10 patients a day. The patient on their first assessment meets a multidisciplinary team. So they meet the nurse, they meet a social worker, they meet a physician. If we need other services, they're available. Each visit lasts, the first visit lasts about 60 to 90 minutes. Follow-up visits last about 45 minutes. Patients come within the catchment area, so within 30 minutes, because there are different cancer centers in the region, so patients don't have to travel too far. Princess Margaret is a referral hospital, so if there are specific clinical trials going on, then patients may come from far, but otherwise patients come from within a 30-minute to 1 hour type of radius to come to the cancer center. In terms of the opioids that we have available, we have morphine, hydromorphone, oxycodone, obviously fentanyl and methadone. So I had to, when I came here, I had to learn about hydromorphone and oxycodone and things like that. I kind of described this only to say how different palliative care can be in different settings, and the challenges associated with delivering palliative care in different settings. I'll talk a bit more about this later when I talk about some specific solutions to improve access to palliative care in both these settings. Next slide. So, I said earlier that when I came to Canada, I thought that you had 100% delivery of palliative care here, but actually, even in Canada, there are underserved populations and low resource settings. So less than, or just 15% of patients received publicly funded palliative home care. So physicians and nursing visiting into the home. I think the most recent statistic I've seen is that less than 50% of the patients who need palliative care have access to palliative care in Canada. And I'll talk about why that is. So next slide. So in Canada, if you look at a map of population density in Canada, you'll see that most of the population is concentrated along the southern border of Canada, which is kind of the least cold part of Canada. And the more you go up north, there's much less population density, much less healthcare availability. So the areas where we have problems with access to palliative care in Canada is rural and remote areas, especially in the north, low-income neighborhoods. One of the things we're doing at Queen's is looking at palliative care integration into prisons. So patients with serious health-related suffering who are in prisons, we're going into the prison to provide some palliative care. Obviously, there are restrictions because of security reasons, because of, we want to be careful about how we manage opioids and things like that. So that's another interesting and challenging area of palliative care delivery in Canada. Palliative care for Indigenous peoples, who many of them live in remote areas. So that's another challenge in delivery. Palliative care for patients who experience homelessness. So we have partnered with the street health programs for patients who are homeless and also have some advanced illness. We're partnering with them to deliver palliative care to that patient population. And then immigrants and refugees to Canada. If you look at studies of health in Canadian immigrants and refugees, they have higher incidences of advanced illness, and they have lesser incidence of access to palliative care. So these are some of the populations in Canada where there are challenges with access to palliative care. Next slide. So what are the barriers to global palliative care delivery? We know that most of kind of the national and regional health policies focus on extending life with relatively less weight given to symptom management and dignity at the end of life. Even in our education, as I'm sure for many of you was the case, it was the case for me as well, that during my MBBS and my MD, I never had any exposure to palliative care. I did my MD in India. So more of the focus is on cure and extending life, and less on good quality palliative care. There's a lot of stigma around the term palliative care itself, and it's usually equated with end of life care. There's a lot of opiophobia, so fear of opioids, misinformation related to opioids, and I'm sure many of you have dealt with this. I still remember in the first few months that I was working in Hyderabad, we had a patient who was admitted to one of the oncology wards and was in severe pain. So we suggested some morphine, and one of the oncology trainees who probably didn't have any exposure to education about opioids wrote on the patient chart, please don't give poison to our patients. So very poor understanding of opioids, very poor understanding of their role in pain management and things like that. Even though there's so much evidence and recommendations from oncology organizations about the role of opioids and pain management. And obviously in high income countries, there's a lot of focus on the non-medical use of opioids or opioid abuse or substance use. without balancing that with the right to access to medications to relieve pain. So these are some of the barriers to global palliative care delivery. Next slide. Some of you might have been already exposed to this. This is the 4 pillars of the public health strategy for palliative care, and that is, policy level work, drug availability, so availability of morphine. And I remember when I was working in Hyderabad, we used to spend hours waiting outside the drug controller office to try and get a license for methadone for our cancer center. And I'm sure many of you have similar stories. Education, of course, is one of the pillars. And then finally, implementation with programs to integrate palliative care. These are the 4 pillars of public health strategy to palliative care. Next slide. So now we're coming towards the end of the slide deck, and then we'll kind of open it up to questions. But before that, I want to share some ideas of solutions that we've used to improve access to early palliative care. One of them is, from Canada, and the other one I'll talk about is a solution from India. So we're working on a trial for symptom-targeted early palliative care. It's called the STEP trial, based in out of Princess Margaret and Queens. And the idea is, like I said earlier, we're trying to define a population that will benefit from specialist early palliative care, and then a population that doesn't need to see specialist palliative care. Even if they don't see specialist palliative care, they're going to do okay. So the research study basically involves screening all patients who come to the cancer center, and those who are above a particular cutoff for ESAS. So for instance, the way we've developed the cutoff is for paid, if you score more than a 7 out of 10, for shortness of breath, if you, sorry, not 7, 4 out of 10, for shortness of breath, if you score more than 4 out of 10, for fatigue, if you score more than 7 out of 10. If you go above that cutoff, automatically these patients are going to be referred to palliative care, to specialist palliative care. And then we're going to measure the patients who are referred to palliative care, the ones who don't meet the cutoff and who aren't referred to palliative care. We'll measure their symptoms and their quality of life. And basically, we're going to have 3 groups. The group that never meets the cutoff, and then the groups that meet the cutoff, the ones who accept palliative care and the ones who decline a palliative care referral. And then we're going to study these 3 groups over 6 months. We already did a pilot trial, and what we found is the groups that don't meet the cutoff, they actually do well, even though we don't see them for palliative care all through the 6 months. So they remain stable. So they're a population of patients who don't need a palliative care team to get involved. Among the patients who screen positive, those who accept the palliative care referral have better quality of life and symptoms than those who decline the palliative care referral. So we're able to show the benefit of specialist palliative care involvement in those patients who need it. So this is the idea of the symptom-targeted early palliative care. The idea is we want to identify strategies that can conserve palliative care resources. Even though, Canada is a high-income country, even in Canada, as we talked about, there are resource and access challenges. So we want to identify ways to preserve our resources. And one way is to see if there's a patient population that doesn't need specialist palliative care involvement and they're going to do fine, and define the population that actually needs specialist palliative care to get involved. So this is an example from Canada. Next slide. The other example I'm going to share is actually developed in Kerala in the 1990s, which is the neighborhood network in palliative care, which many of you might be familiar with. So in this model, community-based palliative care programs will identify and train volunteers in a neighborhood or a village in informal caregiving. And these courses can last a few hours, and they'll include basic caregiving activities such as feeding and supportive listening, connecting with the healthcare system. And these informal caregivers serve the role of a healthcare navigator, so they can connect the specialist palliative care team with patients who are in need, and serve as an additional layer of support for these patients. So this is another example of how in a low resource setting, we can implement strategies to improve access to palliative care. This model, the neighborhood network of palliative care, we're actually trying to bring it to Queen's University. So we've been successful in submitting a grant to work on something similar to this here in Kingston, where we train informal caregivers, and then we see if they can be an additional layer of support and connect with the Queen's specialist palliative care team if needed, that sort of thing. So there's a lot of opportunity for bi-directional learning. We can learn from each other in how to improve access to palliative care. Next slide. So these are a few kind of examples of things we're doing, Pallium India and the Queen's Global Oncology Program. One of them is, of course, we're helping to develop this palliative care fellowship that you're all the first cohort for. We're helping with developing some modules for UGME undergraduate medical education. We're doing some research-related work. So Dr. Yadav mentioned earlier serious health-related suffering assessment tool. So we're collaborating on that research project. We're just working on the manuscript for a scoping review of mental health screening policies in palliative care in low and middle income countries. So these are some of the ways that the Queen's University and Pallium India are collaborating on some palliative care research education projects. Next slide. I think this will be my, the next slide is the last one. So I'm just sharing a comic that we published in JAMA Oncology last year. And this is, again, just to address the stigma of palliative care. So if you see on the top panel, we see an oncologist office and a patient and their family caregiver have just been given a diagnosis of advanced cancer, and a few months later they're kind of drenched in the rain, and the oncologist runs to them and offers them an umbrella, and the patient says, I wish I had this earlier. And then in the bottom panel, the same kind of scenario, but the oncologist offers the umbrella at the time of that initial diagnosis. And so when the rain comes, the umbrella is already there, that they can use it when they need it. So we published this cartoon just to give oncologists a way to talk about palliative care with their patients, because as we know, there's a lot of stigma about palliative care. And here in Canada, when oncologists tell patients that they want to make a referral to palliative care, patients will often say, oh, I'm not ready to get palliative care yet, and they decline the referral to palliative care. So one of the challenges has been, how do we improve the communication so that oncologists can get patients to accept a palliative care referral. So we use this as a metaphor to say that palliative care is like an umbrella. It works best if you give it before the rain starts, rather than after the patient is already drenched in the rain. And so people have been, trying to use this to improve access to palliative care. So I think that's my last slide. So I'm just going to stop over there. I wanted to have a good amount of time just to discuss if people have questions about other aspects of global palliative care, what's different between Canada or other high-income countries and their experience in India. I'm happy to answer those questions and to discuss further. Thank you.
Good evening, sir. I have a question.
Sure, go
Thank
ahead,
you so
Parul.
Yeah, thank you so much, sir, for the wonderful session. Uh, you mentioned about the step trial, sir, and in your pilot study, you mentioned that you are seeing the patients for a 6 months period and assessing whether they actually needed the palliative care or not in one group. I wanted to ask, what are the parameters are you looking in those 6 months to come to the conclusion that they were stable or they don't need the palliative care and they were doing okay despite not inculcating the palliative care physicians?
Yeah, that's a great question, Parul. So the parameters that we measured over the 6 months, and I think we measured it every 2 months or so, every 1 month or 2 months. We looked at ESAS. We looked at a quality of life measure. I think it was FACT-G was the quality of life measure. And I think those were the two main kind of primary endpoints we were looking at. And then we compared the ESAS and quality of life between patients who didn't meet the screening cutoff, and then the ones who met the screening cutoff and accepted the palliative care referral, and the ones who met the screening cutoff and declined the palliative care referral. So the ones who didn't meet the screening cutoff, their ESAS scores remained consistent over the 6 months. And they were all kind of mild. So it was all less than 4. So they never met the cutoff for palliative care. And so that's how we were able to conclude that there is a subset of the population that can remain stable over time and doesn't need a specialist palliative care involvement. Now, that doesn't mean that they don't need primary palliative care. Of course, their oncologists, their family physicians will continue to provide primary palliative care to manage basic symptoms, to manage basic conversations about treatment decision-making and things like that. But don't need a specialist palliative care involvement. Does that answer your question?
Yes, yes, definitely. Thank you.
Yeah. And Dr. Yadav, I see your question. So yeah, I will share that article. It was published in the JNCCN, and I'll just email it to Sripriya, who can kind of distribute it to everyone. I think
Sir, the step trial which you have used, like it's just like an active surveillance among the palliative care patients. That model can be adopted in India as well.
So if I understand the
you have
question,
been checking the like active surveillance for past 2 months. For the 2 months, we have the FACT-G and all those scores, which like an active surveillance which we use in oncology as well for some of the cancers without being treated actually.
That's right.
But in Indian setup and India's model of operandi, where a lot of things which that tool or that methodology can be adopted or some sort of.
Yeah, that's a good question. I mean, in my experience when I was working there, and you guys can comment on this as well, like we rarely saw patients who had a ESAS of pain less than 4. Like almost everyone who was referred to us was in very severe pain, so not even moderate type of pain. So I mean, I don't know. Obviously India is a big country and there are different settings. So a government hospital setting will be very different from a corporate hospital setting. There are probably settings where something like this may be applicable, but I think in most of the government hospital and cancer center type of settings, maybe this would not be applicable because by the time patients present to the health system, let alone present to palliative care, most of the time before, as you know, Ravikiran, from your time in radiation oncology, they're already at an advanced stage by the time they present to you. So, we're not really talking about early palliative care anymore because we're talking about people who are at an advanced and incurable stage, even by the time they get to you before they get to us.
Yes, sir.
Yeah.
Thank you.
Yeah. I saw a couple of hands up right now. I see Punita.
Hello, sir. My question is regarding the drugs now. Now in your kit you have hydromorphone and oxycodone. What difference did you see in using these two drugs? Like we have been in our setup also using only morphine and methadone. Now we have both morphine and methadone here. What is the difference that you see? What is the advantage that you see in hydromorphone and oxycodone in Canada?
Thanks, Dr. Punita. So I didn't catch the first part. Did you say you have a hydromorphone and oxycodone there now?
No, no, we do not.
Oh, we don't have. Okay. So so you said you have morphine and methadone, but you don't have hydromorphone and oxycodone. Yeah. Okay. So oxycodone, the challenge with oxycodone is it's only available as an oral preparation. There is no parenteral preparation. It's available as a short-acting and a long-acting formulation. So we started for some patients, if we don't think that their pain is going to be severe enough that they'll need a parenteral preparation in the near future, we'll start it for those patients. Often we get patients referred to us from family physicians who are already on oxycodone, because in Ontario, it's one of the medications that family physicians can prescribe. So there's a fixed drug combination of paracetamol and oxycodone, and family physicians are used to prescribing that for chronic pain. So because of that, even for cancer patients, they usually start them on it, and then if it's not controlled, they refer to us. So we get a lot of people who are already on oxycodone. So in those patients, we'll continue it. If we have to start a patient who is opioid naive, we usually don't use oxycodone just because of the reason that there is no parenteral formulation. So if in the future they get a pain crisis and we need to give an injectable opioid, we'll have to do a switch anyway. We'll have to switch to either morphine or hydromorphone. So we prefer to start on one of those. To answer your second question about hydromorphone, the main advantage and the reason we use more of hydromorphone than morphine is there's some evidence that it has better renal profile. So in patients who have renal disease, it might be having a better renal clearance. So that's why for those patients, we'll start hydromorphone over morphine. Of course, it is more potent. So there's a 1:5 opioid conversion table. So the typical starting dose of morphine, 10 milligram is equivalent to 2 milligram of hydromorphone. So it is a more potent preparation, but we kind of use it in a patient who doesn't have any renal issues. We will use it interchangeably, morphine and hydromorphone.
How do you compare methadone and the hydromorphone, sir?
Yeah, that's a good question. In our practice, we use methadone more as an adjuvant, especially for kind of a complex mixed nociceptive and neuropathic pain. If we've escalated the dose of the morphine or hydromorphone, 2 or 3 times, we've gone up on the dose in short frequency and it's not really changed anything. The patient says that, I use 8 or 10 of the PRNs doses a day and it makes no difference. My pain is still a 10 out of 10. Then in those kind of cases, especially if we think there's a strong neuropathic component to the pain, we'll add adjuvant methadone. So adjuvant methadone typically is at a lower dose, like 1 milligram or 2 milligram will be our starting dose, and we'll go up on that. Rarely we use a full methadone conversion if we have a patient who develops some kind of neurotoxicity or otherwise doesn't tolerate increase in the morphine or hydromorphone dose, then we'll do a full conversion from that opioid to methadone. But that's more rare.
Dr. That means you use oxycodone or morphine and then use methadone as an adjuvant along with
That's
that.
right. That's right.
Okay. So you don't
Yeah.
do a full conversion and then go to methadone alone.
That usually our practice is to do to use it as an adjuvant. But like I said, it's in more rare cases where we see that clearly the patient is not responding to morphine or hydromorphone or oxycodone, or they're developing some toxicity to it, then we will do a full rotation.
As a palliative physician, both in India as well as in Canada, what have you found as the cardinal difference between the two? I mean, practicing and the type of patients you see.
Yeah, that's a good question, Dr. Gopi. There are a few kind of differences that I found. I think when I first joined and I started, working in the wards, I was shocked by the amount of, the extent to how open patients are to discuss their advanced illness status, their prognosis, and that's a huge shock comparing from India to Canada. And I'm sure many of you have noticed that in India, there's a lot of collusion, families trying to protect patients from understanding what's going on, forget their prognosis, even their diagnosis. Whereas in Canada, patients will directly want to know, how much time do I have left? Can I plan to go on a trip? Can I plan for my granddaughter's wedding? Or what's the death going to look like? What are the things I should be prepared for? So they're much more upfront in their discussions. So initially it was a bit of a shock for me to get used to those kind of questions and to be able to address those questions effectively. That was, I think, one of the main kind of differences I found in practice, that we will go into very frank and open discussions about prognostication, what the end of life will look like, what supports are available at the end of life. And of course, there are exceptions. There are young cancer patients who don't want to talk about any of that stuff, and things like that. But more often than not, you'll see patients who directly will ask these questions. And so you have to kind of be prepared for that and know how to answer those questions. I think that was the one thing. And the other thing was the amount of patients who come alone. One of the things that we're more used to in working in India is there'll be a huge family with the patient, so a good kind of support network. Whereas in Canada, I would probably say the majority of the patients will come alone to their clinic visits. A lot of them will be living alone. They'll be socially isolated. They might have, family that lives elsewhere and isn't really involved, or sometimes is involved, but they're busy with their own lives and can't really take too much of a role in caregiving. And this is a huge challenge in Canada, that patients who live alone and have an advanced illness diagnosis, they have a tough time managing at home without supports. They come to the emergency room a lot because they fall or they can't feed themselves and they get dehydrated and they get delirious, and they have to stay in the hospital, get some fluids and then go back home. And that lack of family support is a huge barrier. So a lot of patients go to long-term care or nursing homes just because they don't have the supports to manage at home. And this is very different compared to India, where usually the rule is there's usually a good family support, and there are members of the family who assist with family caregiving, help patients remain at home for longer. And so this is one of those areas where in Canada, I think there's a lot we can learn from how things are done in India. And that's why that, one of the things I talked to you about was trying to bring that model in Kerala to Kingston.
So there's more of psychosocial and spiritual issues in the patients than what you see here, is it?
I don't know if that is the case, or maybe it's less underdiagnosed, or there's an over preponderance of physical symptoms that have to be dealt with in the Indian setting. So the psychosocial stuff is kind of takes a back seat. You know, as I said earlier, patients that present to our clinics here are often at an early stage. Sometimes the palliative care sees them even before their oncologist sees them. While they're still waiting for the biopsy result, we will see them because they have symptoms. So we get involved very early, and because of that, we're able to get physical symptoms controlled much quicker. So maybe because of that, there's a more of an overexpression of their psychosocial symptoms. Whereas in India, it might be the opposite, because their physical symptoms are addressed at a later stage. That takes a precedence over psychosocial symptoms. But I suspect that the psychosocial burden of disease is, you know, probably the same. I just, maybe it's just underdiagnosed, or of course, you know, there's also the fact that there are more family and other supports to help with the coping.
Thank you, sir.
Yeah.
Sir, another one question, sir. Sorry, I cannot on my video. So how much there is a difference of between India and Canada about the early integration of palliative care in oncology or other fields also, sir? In early integration means when we should when we should decide to stop the chemo or radiation or anything, any active treatments, there is a difference, huge difference. So how we address it?
Right. So Dr. Vidyasarad, one thing I'll correct in what you said is early treatment doesn't mean we stop you know, other treatments. So the model of early integration is based on this idea that you can continue to treat patients for their primary illness, whether that's cancer or a non-cancer illness, so they can continue to get their chemotherapy, radiation therapy, undergo surgeries, and also get their symptoms managed, whether that's by primary palliative care provided by their oncologist or, you know, other primary physician, or by their specialist palliative care team. So the two can go together. How we do that in oncology and non-oncology settings is a bit different because, like I said, palliative care globally is much more well-developed for oncology than non-oncology. We have a few examples of non-oncology clinics. So we have an interstitial lung disease palliative care clinic that I go to once a week. So it's an embedded clinic model. So we go to the pulmonologist clinic and we see patients with idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis has a prognosis that is similar to a stage 3 lung cancer. And they have, you know, significant symptoms like shortness of breath and cough that are difficult to manage. So that's one example of a non-oncology palliative care clinic that we run. The other one that we have is a ALS clinic. So again, this is an embedded clinic where we go to it's a multidisciplinary ALS clinic where we have palliative care, neurology, physiatry, and respirology. All 4 specialties see a patient on their first visit. So it's a long visit. It's maybe takes 3 hours, and all the specialties go in one by one to see ALS patients. That's another example of a non-oncology palliative care early integration. Early integration usually means a clinic model. So we want to see patients while they're still ambulatory, while they're still undergoing whatever treatments are related to their disease. And we see them usually along with the neurologist or the respirologist or you know, other or oncologist, things like that. And Dr. Parul?
Yeah, hello, sir. I have one personal query. I'm still practicing as an anesthetist and I'm still learning about the palliative. I have finished my foundation course and I'm still learning more about the palliative care. I do have a lot of interest in the research thing, and I just want to ask you, like, what should you advise at my level of knowledge and the status proof that I'm still being working as an anesthetist? Should I start my research journey in the palliative care at my own level? What do you suggest?
Thanks, Parul. So it's a good question. I mean, I remember when I was doing my anesthesia residency, I did a couple of research projects, not in palliative care, in anesthesia. So that's where kind of my interest in research started. Because I didn't have a good understanding of palliative care when I was working in anesthesia, I didn't end up doing any research. I always feel like the best research is informed by clinical practice. So you need to see the patients, understand what are the kind of local contextual problems that you want to try and address with a research question. So I don't know if in your clinical practice currently you see palliative care patients. If not, I would say, maybe trying to get some exposure to clinical palliative care is a first step, because that's when you identify that, oh, here's a problem. This is a gap in the knowledge that we can answer with a research question. And there's no substitute to doing that clinical work to understanding what is the gap in the knowledge. Yeah.
Thank you.
There was a question from Dr. Kavin in the chat. Dr. Kavin, I think, what is the role of family physician at your center at Canada, and how to draw a boundary between primary palliative care and specialist palliative care?
Yeah, those are great questions. So the role of the family physician is they serve as, in Canada, we have this model called the patient's medical home. So the idea is the family physician is the patient's medical home. All of the healthcare needs of the patient should ideally be managed by the family physician with specialists involved as needed. Each specialist only sees their own disease-related chunk of the whole. The family physician is meant to see the whole picture. They get the notes from all the specialists. So whenever we see a patient in the palliative care clinic, we'll send a letter to the family physician to say, hey, we saw your patient. These are the symptoms that the patient had. These are the medication changes we're making up for today. Please feel free to reach out to us if needed. And here is our contact information. And this letter goes out from each specialist whenever a specialist sees a family physician's patient. So the family physician is the patient's medical home. They're kind of the captain of the ship. They coordinate, help the patient navigate the health system between many different specialists and things like that. So how do we draw the boundary between primary palliative care and specialist palliative care? So one of the quality improvement projects that we've recently did actually in the last year is whenever we get a referral from an oncologist in the cancer palliative care clinic, we send a letter to the family physician just to say that, hey, we got a referral from the oncologist for your patient. How would you like us to be involved in your patient's care? Would you like us to just do a one-time consult, make some suggestions for you, and then you manage the patient going forward? Or do you feel like you would like us to follow up with the patient on a regular basis? Or do you feel like this consult is actually not needed because you're comfortable doing palliative care and you can manage this patient's palliative care needs? So we send that letter before we see the patient. The family physician sends a letter back to us. Usually they ask us to follow along with the patient. But sometimes there are family physicians who are very good in doing their own palliative care. So they will say, just do a one-time consult, or consult is not even needed. I will manage and I will reach out to you if needed. So it's important to have that communication so that people aren't stepping on each other's toes. Everyone knows what the other person is doing. We don't have two people adjusting someone's morphine dose.
Thank you very much, sir. Sir, one more query is like if the family physicians are being trained in palliative care, that would be a kind of a better bridge between the community as well as with the specialist palliative care. So, do your own institute is having some hub and spoke model kind of a connection between the family physicians, or it is an just an understanding based on integration on kind of things?
So at our institute, because it's an academic university hospital, all the family physician residents, trainees, have to do compulsory rotations in palliative care. So all of the family medicine trainees do, I think, 2 or 3 months in their, it's a 2-year family medicine residency. And in that 2 or 3 months are dedicated to palliative care. So they rotate with us in our clinics. So that's where they get their training in palliative care. And then once they're practicing, they have opportunities for like CPD type courses that we deliver at Queen's, where that they can come and take a refresher course in palliative care. And like I said, we have established kind of channels of communication so that if ever they need to contact us, they know how to get in touch with us.
Thank you, sir.
Of course.
Thank you, Jean. Any one more question before we finish today's session? We can take one more question if there is any. I think there are no more questions. Thanks, Jean, for the patience and answering all the questions they have been asking and sharing your experience both here in MNJ as well as in Canada. Thank you so much for participants for interaction and asking your questions to Jean. Shipriya, over to you.
Thank you, Dr. Jean. I believe the time zone difference would be like that. Maybe you are in middle of your day or something, but still you found out time to engage with the participants. Thank you so much for that. And thank you everyone for making this session as usual very interactive. So with the promise that we'll be seeing in the next session with another interesting topic and yet another eminent faculty. This is Shripriya. Along with Dr. Jean Mathews and Dr. Sridevi, you are here signing off from the Palliative Media Desk. See you in the next session. Till then, everyone, take care. Bye-bye.